Okay, well, welcome everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. A quick note, I've been on active surveillance since 2009, and I'm still a member of my local support group that I got started with. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment but a management plan. I would like to remind everyone that we are not anti-treatment but anti-unnecessary treatment. We are not here to dispense with any medical advice. Nothing said during this meeting by our speaker, ASPI, or anyone in the audience should take place of consultations with your medical professionals. We're going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. You can also click the raise hand button from the bottom of the window toolbar, and if there's time, we'll try to call on you. Please keep your questions limited in scope. Our time here is limited, and our speaker does not have time to review your case history. During the meeting, also, please keep yourself muted. The speaker presenting here today is generously donating his time, and we want to be respectful of that. This meeting is being recorded and will be available on our website in approximately 1 week, and you will get an email notifying you when it's ready. I would like to remind everyone we also have a separate page of 1-minute video shorts derived from our meetings on our website. Last, if you subscribe to our YouTube channel, you will automatically be notified when any videos are posted. I'll quickly add that we're always looking for volunteers, so if you have some time to help and spread the active surveillance word, please get in contact with us. We also appreciate your donations. No amount is too small, so if you can share, please go to our donate page on the website. One last item. We installed our latest version of a clinical trials page for active surveillance on our website. It's considerably more robust than our old one, and we hope you'll have a chance to check it out and find it useful. There will also be a short optional meeting survey for today, which will pop up when you leave the meeting, and uh, we'll hope you'll fill it out for us. So, without further ado, we'll have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest speaker. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Mark.
Thank you. And thank you, Dr. Emberton, for donating your time. We so appreciate that. And we thank you all for joining us today. You all are traveling the road less traveled, and it's becoming more traveled as time goes on, as active surveillance gets to be more adopted. But still, it took courage for all of you to go on this journey together. And we respect that and are pleased to see you here today. And Bill had mentioned about the clinical trials as well. And that's there are a couple of things that are very unusual about ASPI. One is the clinical trials page, and do check that out because if we can support the growth and acceptance of active surveillance through our participation in clinical trials, that's a feather in our caps. The other thing is the shorts. We're the only organization that I know of that has searchable shorts of the videos. So you don't have to sit through a whole webinar, although you should, but you don't have to because you can just search what you're interested in. And so do go to our website and check out the shorts. I also mentioned, and I mentioned this the last time, um, I became very concerned 21 years ago when I fell going to the bathroom at night. And so this past month I searched that issue of falling and being injured when you go to the bathroom at night. And so I did an AI search on that, and I found out that there's thousands of men that are falling when they get up to go to the bathroom at night. And so I did a story on that, and it's on our blog. And I'd encourage you. My remedy 21 years ago was to use a urinal. So I never get up to go to bed, to go to the bathroom. I just use the urinal. Cancer's complicated. This idea of reducing injuries from falls is simple. It's not complicated. Yet, for some reason, I don't understand why it never has gotten any traction. And but I do what I can. And so, if you get a chance, check out the story on the falls. With that, oh, and just a reminder, we're gonna do our support group. That's become very popular. So stick around afterwards if you want to chat with some other active surveillance patients that are going through what you're going through. With that, I'll introduce my good friend, Howard Walensky.
Okay, thanks, Mark and Bill. Hello, everyone. Greetings from Chicago. With over 500 of you registered today and almost 200 of you present, it's clear this community is as passionate as ever about getting the best information on active surveillance. We're thrilled to welcome back Dr. Mark Emberton, Professor of Interventional Oncology at University College London, one of the true architects of MRI-based prostate cancer care. Dr. Emberton led the landmark PROMISE trial and helped make MRI-first diagnosis the standard of care across the UK, where over 90% of hospitals now offer it. Here in the US, only about 35% of men get an MRI before biopsy. Dr. Emberton has pioneered MRI-guided biopsy, MRI-based active surveillance, and focal therapy, reshaping guidelines worldwide and giving men like us the confidence to surveil our cancers safely. He joined us last year discussing MRI invisible lesions, and we're bringing them back by popular demand. Today's topic is prostate biopsy, the beginning of the end. Dr. Emberton will make the case that advances in MRI technology are bringing us closer to a future where the traditional needle biopsy, with all its discomfort, anxiety, and risk of infection, may no longer be the default first step for most men. For those of us on active surveillance, that could mean fewer invasive procedures and a safer, less stressful monitoring journey. After 15 years on active surveillance, I can tell you personally, Dr. Emberton's work has made my journey and our journey less frightening and more informed. Please welcome Dr. Mark Emberton. The floor is yours.
Well, it's extremely kind of all of you to invite me once again. It's a real privilege to be with you and work with you on some of these kind of new ideas. And actually, I see this as a two-way thing. I'll share some ideas with you, but what I really value is the discussion afterwards and the feedback that we get. And if we don't have time today, Howard knows I'm always happy to answer emails if there are kind of any outstanding issues. So I've been asked to talk about biopsy and about the kind of end of biopsy, as it were, and whether that's likely to happen. I think it's happening already. And let me just see. So here's you can see my first slide. When I was training, and in fact, when I was a kind of young urologist, everybody with a high PSA got a biopsy. It was a kind of linear pathway. There was nothing else that you could do. Ultrasound couldn't see the cancer, and the only way to tell somebody that they had cancer or they were free of cancer was to do a biopsy. And of course, people didn't just have one biopsy, as many of you know. Once you've had one biopsy, the propensity for having a subsequent biopsy is great. Today, in Europe, in London, in England, about half the men that we see with a high PSA undergo biopsy. And that's largely due to MRI. There's maybe a little bit of biomarker effect in there, but it's principally due to MRI. And I'll discuss, who those men are. And I suppose it's legitimate to ask just how far this trend can go. with all the developments that we're getting in imaging, in AI, in feature extraction, with the biomarkers that you all know, how precise can we get in terms of the prior probability of ruling in or ruling out clinically significant prostate cancer without putting a needle into the prostate? And of course, what's behind this? Well, biopsies are costly. There are about 5 to 6 million biopsies done every year throughout the world. Obviously, there's a huge drive everywhere for clinical efficiency. If we can take elements out of the pathway, speed things up, reduce harms associated with care, we can improve benefit, decrease harms, and also decrease costs. And those of you that were here for my last talk, behind all this, I think there's a general move away from a kind of histological way of thinking about the disease to more of a kind of radiological way of thinking about the disease, which is how we conceptualize most other cancers. If you have a headache and you go to the doctor and the doctor's worried, you do a scan. If your scan is normal, you're told you've got nothing to worry about. The dreaded cancer isn't there, and off you go. Same with liver, lung, kidney, etc. And I think in prostate we're getting into that kind of era, and so we're thinking about the presence of or the absence of a lesion rather than the presence or absence of histological cancer that may or may not be there when we stick a needle into the prostate. So that's the kind of the background thing that I think is driving a lot of it. That's probably the hardest bit to explain. But I think my talk last time goes into some of the new thinking about that. So we've already heard that men want to avoid a biopsy. I've yet to meet anybody that enjoyed the process or indeed was looking forward to the second exposure to the process of biopsy. As you can see, there's discomfort, bleeding, infection. Septicemia has become a really big issue, particularly with transrectal biopsies. Many jurisdictions around the world gave up on transrectal biopsies a long time ago. I haven't done a transrectal biopsy for over 15 years now. Everything's through the perineum because we can sterilize the area. Doesn't make it completely free of risk because individuals can have bacteria on their skin that are resistant both to some of the antiseptics and also to the antibiotics. And if you're not careful in the perineum, you can get pretty close to the rectum and sometimes breach the rectum, particularly for a posterior lesion. That obviously becomes a transrectal biopsy inadvertently, and you don't give the appropriate antibiotics. Deaths have been reported from biopsy, as some of you know. Biopsy delays the final treatment. As you know, you have to wait for the biopsy, you have to wait for the result, and then when you get the result, the surgeon says to you, I don't want to operate for about 3 to 4 weeks because I want the biopsy to settle down. So suddenly you're thinking maybe 3 or 4 months delay, systematic delay in treatment, which may or may not matter, but usually with a cancer diagnosis, most people want to be treated early. Cost obviously varies depending on where it's done and how it's done, but biopsy is getting more expensive now. So the quick biopsy that many of the audience experienced, which was done in the office of the urologist with local anesthetic, with maybe just one nurse present, is now transformed into something that's done in a kind of operating suite with image fusion, MRI, targeting of biopsy. There are robotic biopsy machines coming along now that work inside the MRI. So what was a kind of cheap and simple thing is now a lot more complicated because we're now targeting and there's a very exacting spatial resolution that needs to be worked through. And of course, biopsy is always sampling. Many of you will have been told you're all clear, and then a subsequent biopsy tell you that you're not, and indeed the other way around. Because of the inherent unreliability of biopsy, a man can go from, yes, you've got cancer, to on a repeat biopsy, actually, we can't find it this time. And I'm sure many of you had those conversations. So there's implicit unreliability in the test, and poor reliability always impacts on validity in a negative manner. But some of the other worries that many men have. So when people come to me and say, I'm worried about the biopsy, and many physicians have done that. So in the PROMISE trial that was mentioned just earlier, we asked men to have really extensive biopsies because we want to prove without doubt whether the MRI was correct or not. So we developed this reference standard. Participants were incredibly generous in terms of the amount of biopsies they let us do, and that was necessary to kind of move the world on, as it were. But we didn't manage to recruit a single physician into the PROMISE study. And I remember having conversations with at least 5 of them who wanted to avoid that process of biopsy. And the worry about biopsy is not just the harm that I talked about about spreading the cancer, about changing the nature of the cancer, or about seeding the cancer into other compartments. So obviously, you've got an organ-confined cancer, you put a needle into it, and these days we do that several times. There's a worry that you will contaminate other parts of the pelvis outside the prostate with those same cancer cells. Now, whether or not these things are true, they are real in terms of beliefs that people have. And some of these beliefs, I think, are very legitimate. They just haven't been looked at very closely. And this is the kind of schema of what a biopsy might do to any cancer, not just prostate. You can see several of these through the literature, but essentially what a biopsy does is it creates a wound through the process of inflammation. A wound basically allows the cells to become less sticky, and it allows cells to reorganize. It allows the blood supply to be regenerated. It allows macrophages, mast cells, all kinds of cells to come in and allows cells to move around so that the tissue can be remodeled and ultimately replaced by scar tissue. And people have worried for a long time of the effects on trauma on cancer. And here you can see, all the kind of processes. In fact, all the aspects of trauma you can see around this circle, leading ultimately to metastases. We're going to cover some of these very, very shortly. And there have been many models of cancer. These are animal models, not human models, in which an animal model can have a cancer, but it only metastasizes if you put a needle into it. And the most famous one is called the murine sarcoma model. So it only metastasizes when it's traumatized, largely because the trauma starts the cascade that you're seeing on this slide. Let me give you some example here. So this is a patient of mine who I'd been watching for a while without a biopsy. This is an MRI scan. He has a very large prostate. And here you can see the urethra. He has a small tumor here on the right, posteriorly. He has another tumor in the top left of the prostate and also in the right anterior horn, you can see there. And the reason we thought that a biopsy might be prudent is that he'd gone into retention, he was teetering on re-retention, and we were going to do a holmium laser prostatectomy to get rid of the bulk of this tumor before addressing his prostate cancer. He was too old for a radical prostatectomy and didn't want radiotherapy. So the biopsies were targeted. We don't do random biopsies. We just target the areas. You can see the image fusion here. And this is a kind of recreation of the needle deployments that I did for several of these tumors. The apical one you can't see here because we're mid-prostate. So the apical one is coming out of the screen. But I'm going to show you the process of biopsy now. And this is this individual being biopsied. I'm biopsying the apical tumor, which is down there. And that one needle's just gone in. But I just want you to keep an eye on the blood vessel. And there are arrows pointing to the blood vessel. And after each needle deployment, you'll see debris, tumor material, going into the blood vessels. These are veins, periprostatic veins. You can see the materials here, and you can see them coming out in a blood vessel fairly far away. I'll just repeat. I'll repeat that again so you can see. This is modern biopsy, it's targeted through the perineum, and actually we're looking at the periprostatic venous plexus. And following the biopsy, you can see debris that is passed into the vein. There's nothing new about this. I'm just kind of illustrating to you something that happens every day in every office suite all around the country. The question is whether this is significant and important. And obviously, not only are we entering a blood vessel here, the needle, and there's a couple of papers showing the ballistics of this. The way the needle works is that there's a bullet that comes out at with huge force and great kinetic energy. And just like a high velocity bullet, it causes a cavitation to create. So it pushes the tissue out, and then the tissue recoils into the space left by the bullet. And then a second chamber comes in to grab that tissue. And obviously, when the tissue recoils, there's a backsplash of pressure. And that's what we're seeing here. And so again, I'll show you once again. So that's that process happens in microseconds, but the backsplash of tumor material you can see going into I can't prove that it's tumor material, but it's material from the prostate going into the blood vessels. And we do that with targeted biopsy not once, we do it several times, and that's new. When people had random biopsies, you were lucky if you hit the tumor once. You usually miss the tumor. Today, we know where the tumor is, and we hit the target several times, 4, 5, or 6 times, in order to get the kind of certainty that we're after. That's a huge amount of kinetic energy to the tumor and to the prostate, which may have consequences. So, do we have any evidence that the cancer cells get into the blood after the biopsy? Well, we do. You don't have to look too hard. And so this is a 2020 paper, which until I looked for it, nobody had ever quoted it, as far as I could tell. I've never been to a talk where people said, "Oh my gosh, there are circulating tumor cells after a biopsy." But that's what they showed. Obviously, this needs to be repeated. This is one paper from quite well 6 years ago now, and what it showed was a huge increase in prostate cancer circulating tumor cells in men who had a biopsy who proved to have cancer. Right? You don't find cancer circulating tumor cells in people who have a biopsy who don't have a cancer. And you can see the odds ratios there increasing dramatically if you have a biopsy with cancer in it. So a 7-fold, well, actually, if there's no cancer, you have a very, very small chance of having it, but a 7-fold or 8-fold difference between the two. And what was fascinating about this paper is that it showed if you had a increase in prostatic circulating tumor cells after the biopsy, you did less well after radical prostatectomy. So all these patients went on to radical prostatectomy. Now, the men that were identified as having circulating tumor cells that were prostate cancer had greater progression rates following surgery. Now, this may be nothing to do with circulating tumor cells. It may be that more aggressive cancers are more likely to spread circulating tumor cells into the blood, and you're finding it, and it's just a proxy for aggressivity. So it's not necessarily causative of the biopsy, but nevertheless, the presence of circulating tumor cells here is associated with a poorer prognosis, and the process of biopsy certainly increases the proportion of circulating tumor cells. So already one's beginning to kind of have concerns. What about this issue about migration? Can a biopsy actually seed the tissue into the tract? Well, some of you have mentioned a transrectal biopsy. This is a case from just 2 years ago, 2024, of a individual undergoing a transrectal biopsy for what is a large posterior Gleason 4+4 adenocarcinoma. They developed a lump in the rectum, in the anterior rectal wall, which you can see there on colonoscopy, but you can also see it on MRI. And that was biopsied, and it was an adenocarcinoma of the prostate. There was PSA in it, the adenocarcinoma was not arising from the rectal mucosa, and that was deemed to be a cancer from the biopsy that was seeded into the rectum. Now, there aren't many reports of this, and I've never seen it, so it's rare, but this shows that it can happen. And what we don't know is how often it happens. Obviously, it appears on the skin or in the rectum, you can find it. But if the seeding is more subtle and is around the prostate, then it would just be a part of the whole progression story. So, so it would just be part of the kind of rising PSA after prostatectomy, which we call progression. But some of that might be due to the process of biopsy, putting seeding of cells outside the prostate. And we know that many of those patients who have radiotherapy to the prostate bed get better, even if their original prostate was organ confined. So you have to ask the question, how is it that they progressed if they had surgery for organ confined disease that was specimen confined at pathology? And I suppose the biopsy is one way. What about when we switch to perineum? Here's a PSMA PET scan of something that lights up very, very brightly in the perineal skin. You can see it here. This was a lump soon after. I think this individual had a prostatectomy after the transperineal biopsy and then got some recurrence. Gleason 4+3. So these lesions tend to be fairly aggressive. We've seen a 4+4 and a 4+3, or these are the ones that are getting reported. And it was excised, and it was an adenocarcinoma of the prostate. And again, this was never reported before we went down the transperineal route. So again, rare. I've never seen it. My radiologist tells me he's got 3 cases like this of perineal recurrence.
In another week, you should watch it.
I can hear somebody speaking. Somebody's unmuted. So is there anything we can learn from other cancers? There's been very, very little research into the adverse effect on prostate cancer from direct trauma from biopsy. But our colleagues in breast cancer have done quite a lot of work and actually have published fairly extensively. The details of this don't matter terribly. And here they looked at the biopsy. Obviously, you take a biopsy and then you process that tissue very quickly, so it doesn't have time to undergo inflammatory change. And then they looked at the breast that was biopsied, and that was removed 25 days later on average, to see if the area around the biopsy was different to the other parts of the breast. And they showed really quite dramatic differences in TGF beta, transforming growth factor beta, which is associated with metastatic spread. And that's in the cancer, that's the needle biopsy and the surgical resected specimen. You can see the increase there, and this is in the stroma of the breast. And there's also a dramatic increase in the stroma of the breast compared to the needle biopsy of these CD8 and CD4 T cells. Again, demonstrating a change in the immune spectrum of the tissue that followed the biopsies. Whether this is detrimental or not, or a good thing, I think we can keep an open mind. But the story builds. So this is fascinating. There's a concept in breast cancer I didn't know about until I started looking at this, that and they call it the biopsy to treatment time. And if the biopsy to treatment time in breast cancer exceeds 50 days, you can see the mortality risk goes up almost exponentially. So as long as you have your treatment within 50 days, the mortality stays flat. If for whatever reason your breast cancer surgery is delayed, the mortality goes up dramatically, as you can see there. And I think on this slide, you can see that if you have your breast cancer treated later, following your biopsy as time 0, then you do worse on average in terms of mortality. This is not progression. This is the risk of dying of prostate cancer. And this group, so this is an American group, as you can see here, Thomas Jefferson, Philadelphia, started to kind of look at why. And they showed pretty dramatic changes. So they were looking, this is breast tissue, this is the biopsy wound, and they looked at tissue adjacent to the biopsy versus tissue that was distant to the biopsy and showed a reduction in E-cadherin. E-cadherin is something that keeps cells sticky, keeps cells where they are. If they're reduced, they can become more mobile. In fact, metastatic cells are associated with a reduction in E-cadherin. So again, you would expect this around a wound. This is what the process of creating a wound does, but nevertheless, it's been demonstrated. So this reduction in E-cadherin was caused, I think we can say that fairly emphatically, by the trauma associated with the biopsy. Here again, we can see changes, and so again, this is a kind of change in the immune in the T cells, so of the immunity of the breast. And what we tend to see in wound healing following a biopsy is a shift, what they call from epithelial to kind of mesenchymal transformation, and that is part of this loosening up of the tissue to allow tissues to migrate, which you need in every wound for the healing process to occur. And that's thought in cancer to be detrimental. And again, proof that there are changes, not proof that these changes are indeed detrimental. But you can see the whole picture building up quite a bit. And they drew a very similar picture to the one I showed you. But actually, interesting, they were postulating whether there was something we could do. So whether administering anti-inflammatory agents might, after a biopsy, might suppress the inflammatory response and the immune changes that result, and make the process less likely to proceed to a kind of metastatic type picture. Now, that's obviously a hypothesis that they generated, backed by a huge amount of data. Should you wish to look at their paper, which I'd certainly recommend. It's quite hard work, but there's a huge amount of data in there. And then this one, I think, is my last one from breast. Is fascinating. This was a while ago, and this was some Swedes, and they thought it would be interesting to look at the transition from a fine needle aspirate of breast, which is what they used to do in Sweden, and then they switched to the core biopsy, which is what we do in prostate. And they showed in this paper that the amount of kinetic energy that you're administering to the tissue is about 1,000 times greater with a core biopsy than it is with a needle biopsy. And so the needle you push in with a finger, so it has very, very low velocity. The core biopsy, by a huge spring, there's enormous difference in velocity. So they thought it would be really interesting to see whether that change resulted in any change in outcome. Now, these are difficult because these are before and after studies. So you look at a historical group of patients, and then you look at a new group of patients, and clearly lots of things change between the historical patients and today's patients. And so you have to be very clever in making these comparisons, or very critical, sorry, in making these comparisons. And the investigators have to be very diligent in trying to adjust for everything that they can to try and make the two cohorts look similar. Now, obviously, one was in the 70s and one was in the 90s. Care has changed hugely during that time. What they did do was limit the tumor size to small cancers to try and mitigate the effect of screening, which came in late. And then they picked a small component, about half of the 70s patients and about 10% of the 90s patients, to create a kind of matched cohort. And they did pretty well, actually. So obviously, if they didn't have data on the tumors, they were not included. The number of tumors that were less than 20 millimeters, you can see there was no significant difference. There was no significant difference in tumor size. Large tumors were, as we say, were not included, but in the overall cohort were no different. And interestingly, sorry, I think what I can say is that the patients that had the core biopsy, so the latter patients, were much more likely, or I don't know about much, were more likely to have radiotherapy in addition to their surgery than the patients that were treated in the 70s. So the core biopsy patients had more treatment, okay, and also I think the tumor volume was just slightly greater in the tumor. No, the tumor volume was again non-significant. If you looked at the cancer cells in terms of the DNA that they contained, again, there was no significant difference between them. So despite 2 or 3 decades difference, they've managed to kind of identify a cohort that was roughly similar, apart from the core biopsy patients, the patients that were biopsied more recently, who had more treatment. There was kind of more availability of radiotherapy. And this is what they showed. So this is looking at the proportion of distant metastases developing, and you can see that the women that received core biopsy were more likely to develop metastases than the individuals, the women that had the fine needle aspirate, despite the women who had a core biopsy receiving more treatment. Now, again, this isn't proof, but they did as much as they could to adjust for everything that they could adjust for. Of course, you can't adjust for the things you don't know about. But despite more treatment, the women having core biopsies had a greater risk of metastatic spread, which again just makes you pause. And given what I've just shared with you, the kind of theoretical changes that are being discovered since this was published, again, it makes you think. So that's kind of where we are. There are probably maybe 2 or 3 or 4 times as many papers as I've shared with you out there. So there isn't much out there, but I've given you a kind of flavor of what is out there. And I think a story is developing that trauma to cancer may not be a good thing. So what is interesting is that there's been very little work in urology, and particularly in prostate cancer, to see whether biopsy in general, or modern biopsy in particular, which targets the cancer and hits the cancer several times, is in any way detrimental in terms of onward progression. So that's the background. How can we avoid biopsies today? So I said, I think one of my earlier slides, maybe my first slide, is that about half the men today avoid a biopsy. If you have a normal MRI, just like if you have a normal brain scan, or a normal mammography, or a normal lung CT, if you're a smoker, you're reassured. We do the same with prostate. I haven't biopsied a normal MRI for well over a decade. And so, the only people that really get biopsied now in the UK are people with PI-RADS 3, 4s, and 5s. What we are learning now is that certain PI-RADS lesions, that if you biopsy them, the yield is very low. The yield is similar to doing a kind of random biopsy. And some PI-RADS lesions are diffuse. You see those in young men. There's very little utility in sampling those because you're sampling randomly. You're not directing your needles at a cancer. Most of those men will be reassured. We've also got plenty of evidence showing that if you have a PI-RADS 3 with a low PSA density, in other words, a PI-RADS 3 in a big prostate, again, the yield is exceptionally low. We're also learning that if you're MRI negative and PSMA PET negative, then the chances of having prostate cancer are close to zero. I mean, they're pretty close. They're pretty close to zero anyway with MRI. But if the PSMA PET augments that, we're learning that the prior probabilities shift in another direction. And then the other kind of really interesting area at the moment, and this is getting lots of attention now, is prior to radical prostatectomy. So there've been 4 papers now published showing groups of individuals going straight to radical prostatectomy because the probability of having cancer was so high that they thought it was a waste of time and indeed an exposure to undue harm to undergo a biopsy. And I'm going to share some of those with you. So that the half of the men that can avoid a biopsy today, in my practice, are men with a normal MRI and men with PI-RADS 3 changes that are kind of favorable. Or indeed, men, and I'll show you one right at the end of the talk, with a PI-RADS 4-5 lesion, which is small and wishes to observe it. So we can instead of doing a biopsy, we can just use time to see if a lesion progresses. All lesions progress, but some take longer than others, again, as I'll show you later. The big change, so if we can persuade men to forego biopsy who are going on to radical prostatectomy, we'll probably get up to kind of 80% of patients avoiding a prostate biopsy. Let's see what you think of the data. But before I do that, I think it was Howard that said that only 35% of men in the USA get an MRI, because to avoid a biopsy, you have to be offered an MRI before it. And I was reassured, well, 35 is still terrible, but it's better than this paper that was published last year in Urological Practice. And this is obviously a population of Medicare claims. But in this population, and this is a very respectable group from Boston, only 1 in 20 beneficiaries of this study received an MRI scan prior to a biopsy. 1 in 20. And rural men were less likely to receive one than urban men in this group. Maybe some of you will help me with this later on and tell me what kind of individuals this is portraying. But I think we were just shocked when we read this. It was, and obviously you can't avoid a biopsy if you're not offered an MRI. So this was the first prior to radical prostatectomy paper. It was a slightly odd paper. And it was from German colleagues. And basically, they reported all the patients that they'd done radical prostatectomy on who had refused a biopsy beforehand. What was amazing about the paper, and it caught my eye, was that actually all the patients had cancer when the prostatectomy was removed and looked at histopathologically. So not many patients, 25 patients, 52 lesions over a 5-year period. Wasn't a trial. This was just colluding professionals and patients agreeing that this was an okay thing to do. And the way they got to it was to be MRI positive, PSMA PET positive. And I think I've got and so you can see here that the sensitivity for clinically significant disease was 98%. And the positive predictive value, 87%. So all the men had cancer. By far, the majority of men had clinically significant cancer. And you can see here the cancer in the right anterior component of the prostate verified on the histopathology. So it's interesting so this got quite a lot of attention. By avoiding a biopsy, you have 100% certainty of having prostate cancer when your prostate's removed. Had you biopsied these individuals, a group of them, even just out of the 25, would have been given the all clear incorrectly, such as the nature of biopsy, because you're always sampling. You've got to hit the target, but also you've got to get the tissue, and that's an imperfect process. And so some of these individuals would have had their cancer treatment delayed. 1 or 2 might have got sepsis or bleeding or whatever. And of course, as I'll show you in a minute, if you insist on a positive MRI, positive PSMA PET, you select really quite aggressive cancers, and the process of biopsy may have been deleterious in terms of curing the cancer, if we go back to my earlier slides. So this set the ball rolling. This was 25 colluding men with kind of urologists that were willing to take their preferences forward, and then they kind of published as a series. This was the first formal trial, and this is 2025. So this is all very recent stuff. And these are Chinese colleagues, and they did it a bit more formally. So basically they started with 371 men, MRI positive, PSMA PET positive, that you can see here. But of all the eligible men, only 57 men, still twice as many as the German.
The same number.
Um,
They
and again, somebody's been muted. So basically here you had to have a positive MRI and a positive PSMA PET and a high PSA density. So they added that last little bit over and above the German study. And if you had that, then you went to radical prostatectomy. And basically, 100% of the men had aggressive, clinically significant prostate cancer. There was 0 benign cases. 1 man in the group had Gleason 3+3. So you can see that if you select for MRI PSMA PET positive, it's 100% chance of having prostate cancer. And that's in 2 studies, a German study and a Chinese study, or a German report and a Chinese study, that you can see there. And then I think this is the last, this is just published the other day. So this is kind of hot off the press. But it shows exactly the same. And so the men had to go through similar case selection, MRI positive, PSMA PET positive. So basically it starts with a high PSA and an MRI lesion. So that's kind of like everybody. Yeah. So if your MRI is normal, you're sent back to the general practitioner. But if you've got a PI-RADS lesion, you don't go straight. You have a PSMA PET next, and then if they're both positive, you go down the route to radical prostatectomy. And what do they show? Exactly the same. So you can see here, every man had prostate cancer. In this group, 0 3+3s, so they were all clinically significant. And you can see some pretty aggressive cancers were found. And all these men went straight to surgery, managed to avoid a biopsy, managed to avoid any detrimental aspects of a biopsy, and got their treatment as soon as possible. So I think that's really quite compelling. And it'll be very, very interesting to see what people think about that later on. So if you've got a lesion on MRI, what's the next thing you should do? So most men would be offered a biopsy. Maybe the next thing is to do a PSMA PET. And then if they're both are positive and actually surgery is the thing you're going to do, why go through a kind of completely unnecessary process? Why not go straight to surgery or indeed some other treatment? The beauty about surgery is that you get the pathology anyway. If you have radiotherapy or focal therapy, perhaps you don't. So with that, I think we can say that we're getting pretty close to a virtual biopsy. So if there is adoption of the straight to prostatectomy, about 80% of men who otherwise would have got a biopsy will manage to avoid it. Some will go straight to treatment. Some will have a phased period before they go to treatment. But why is this going to? Our imaging is going to improve. The utility of Gleason score, I think, is getting less and less. So when you do targeted biopsies now, you tend to find Gleason 3+3 as the dominant. Sorry, Gleason 3+4 as the dominant pattern of that you see down the microscope. Also, we're learning about radiomics. AI is getting better and better at feature extraction, so it's able to tell us things about the MRI and the PSMA PET that we cannot see with the naked eye. And I haven't yet mentioned ultrasound. So there's lots of people out there that think that the speed of sound is a very important component of cancer aggressivity. And you'll be aware of the micro-ultrasound diagnostic process in the paper that Laurie Klotz published, and he may have spoken to you about that. And I've not yet spoken about companion biomarkers, but I have mentioned, well, I haven't mentioned it, but the PSMA PET has also brought a very important aspect here in that it caps the risk. It tells us with relative certainty that there are no metastases present. And before PSMA PET, we couldn't really do that with bone scans and CTs. So all these things are changing the advice that we give men, and the direction, I think, is fairly clear. Let me give you some examples of things that are real things that are happening now. So this is a bit of post-processing of the diffusion component of MRI. This was developed by our team at UCL. You'll see some familiar names there, including my own. And this is just a little bit of software, really, to help you make sense of the tumor. And you can see that with natural diffusion, it's very difficult to recapitulate the underlying histopathology. With verdict diffusion, you can. There's a statistically significant ability to differentiate and discriminate between low-risk lesions and higher-risk lesions. This is a non-invasive way of giving us a very good prediction of whether Gleason 4+3 is present or Gleason 3+3 is present. AI, I've mentioned. I mean, this is probably another lecture, but there are lots and lots of companies out there now offering to make predictions on the lesion based on their algorithm. And we're going to hear a lot more about that very soon, because there are some very big companies getting involved in that. There are new sequences being developed. So this is happening. Verdict exists. AI diagnostic systems exist today. This is under trial. Again, this is a new sequence we've developed called luminal water fraction imaging, and it tries to recapitulate the underlying histopathology. And it's a 5-minute T2 sequence that we use. And basically, it's looking for the amount of ductal architecture within the prostate cancer. As cancers become more aggressive, the proportion of ductal architecture diminishes and it's replaced by sheets of tissue. This seeks to recapitulate that in a non-invasive manner that is repeatable and reproducible. In future, and I think this is just hyperpolarized MRIs available today, but it's very complicated and very expensive. There's a German company about to release a bit of kit that is going to be transformative. In that currently we might be able to do 1 or 2 a week. With this new bit of kit, we can do 40 to 50 a day. And this looks at not the cancer cells, but it looks at how the cancer cells generate energy. So in other words, how they make pyruvate, how they use sugar basically to create energy. And so you're looking at the metabolic profile of the cancer through this technique, which again will give us additional information that hitherto we had no access to. Again, completely non-invasively. And of course, this is something that you could repeat over time to see if your cancer is getting worse, particularly very useful in active surveillance. So, why is imaging superior to a biopsy? Well, I've just alluded to it. I think more accessible, right? It can be repeated. The beauty about imaging is that it's reliable. If you image something twice in a day, it's the same. If you biopsy something twice in a day, it's always different because of the nature of sampling. The other thing that's kind of interesting about imaging is it's the end product of all the genes and the post-processing and the methylation that we see in the cancer. When you look at genetics, you're looking upstream. When you see the imaging, you're looking downstream. The histopathology is probably somewhere in the middle. And what we're learning from the imaging is not only can it tell us whether a cancer is present, but the nature of the imaging can also give us some idea about its aggressivity. And this is just looking at ADC. ADC is a component of diffusion. So the lower ADC, the more packed the cells, the more aggressive the cancer. And you can see if you have a low ADC, you do a lot worse after prostatectomy. And these are all men that had radical prostatectomy, and they are stratified by their diffusion component, high, moderate, or low ADC. Again, here you can see that non-invasively, we're able to make kind of predictive, we're able to stratify in terms of risk prediction. The other thing that I think is worth dwelling on is the dimensionality of imaging that's emerging. And imaging allows us to look at lots of components of the tumor. And this is just a kind of spread, if you like, of PSMA PET MRI positive lesions. This is a PSMA positive MRI negative lesion. This is a PSMA PET negative MRI lesion. And this is a lesion that wasn't seen on either. Of course, the smaller the lesion, the greater the chance that it's not seen on either. And you could add ultrasound to this, and you could break down MRI to T2 positive, diffusion negative, DCE positive. So in other words, the three components of MRI. And you can see that you could create a very complicated taxonomy of disease, which we haven't even started doing yet. We don't really know what it means if you're PSMA PET negative, MRI positive versus the opposite. In this study, the bigger the tumor, the greater the risk that both would be positive, which kind of makes sense. So how might the future look? And I'm coming to the end now. So this is a very modern individual. He's had a very high quality MRI scan. He's got a big prostate. That's how he presented because his PSA was high. And he's got a tiny tumor in the peripheral zone of the prostate. This is about the earliest that we can detect prostate cancer. For those skeptics amongst you, you can see the lesion both on the diffusion ADC and on the gadolinium. You can see a tiny little bit of blood supply in the area and a little bit of ADC defect, but it's probably easier just to look at the T2. And so with MRI screening, that's another talk, maybe for the future. These are the kind of lesions we're going to identify. And so you have a number of options. You can watch it and see if it grows. We know all lesions grow, but they vary hugely in the rate at which they grow. And we know that lesions, which are basically organized tumor masses, have periods of quiescence where they don't grow. And then they have a sudden growth spurt, which may be the result of a change in the immune system or a genetic mutation that allows the cancer to do something that it couldn't do beforehand. Equally, you could treat it and get rid of it in the same way that you would get rid of a small skin cancer on your forehead, and it would not be difficult to ablate a small amount of tissue in a selective manner. Or I suppose you could biopsy it. So again, which of the three are we likely to do? This we published last week, I think, or the week before last, very, very recently in European Radiology. You can see 2026 here. And this is the natural history of lesions. A cancer, we think, has to be about 17 years old before we can detect it. But the first time you can detect it is I think, on MRI. You couldn't. If you'd done random biopsies on that prostate without MRI, I think you'd probably have to do 1,000 biopsies before you hit that tiny lesion, and you'd never be able to hit it again, just in terms of probability. And you can see here that once the lesion becomes detectable, the growth of the lesion increases in an exponential manner. There's a little bit of difference between the 3+3s and the 3+4s, but I wouldn't pay too much attention to that because I think that's not a very reliable risk attribution. But what's interesting is that all lesions progress, but they progress very differently. And each line you see here, which looks like a kind of child's kind of crayons scribble, represents a lesion within a patient. And you can see some grow very quickly and others actually stay flat for a while. But the general trend is upwards. And if watched long enough, all lesions will grow. I've never yet seen one disappear. And so you could argue that actually the thing to do is to, when you seek out a lesion, to destroy it. But I think there's also time to monitor it for a period to see if it grows and then have treatment later. But that treatment inevitably will be more because the lesion will be greater and more margin will need to be applied to it. Just to reassure you that I'm not alone in thinking about virtual biopsies. There are other people having this kind of thought now. This again was published quite recently, just last year, and a group of individuals developing a kind of AI approach using all the inputs and then using kind of an AI calculator to work out and calculate the likelihood of you having a prostate cancer, and indeed if you did have how that kind of prostate cancer would look were it to go to biopsy. And I think we're going to see a lot more about that. With that, I can assert that the direction of travel is clear. We've already got halfway. I think there's another 30-40% that we can do quite easily, and I think the last few percent will be difficult. We haven't even started embracing the technological advances that are out there. I think we need a lot more work on whether the biopsy itself is harmful in terms of making the cancer worse. And we are committed at UCL to do that. And we are seeking funding at present to run a series of trials of men who have biopsies and men who don't, and to see if we can see cancer cells in the blood, look at the immune system, etc. It's not something that grants are willing to fund at present. So it's largely through philanthropic donations. So if any of you want to support the work, just contact me. We've already got quite a bit of funding to do that. But we want to do it really well, and we want to do it quickly because we think it needs to be done. And these clinical studies remain very challenging when you're randomizing men to biopsy versus no biopsy, which we have to do. And remember, nobody's done that yet. I haven't shown you a single trial where that's been done. You have to do that to see if there's a real difference between the two. It's going to be very, very difficult. With that, thank you once again for indulging me with your presence. I hope some of what I've said will stimulate some thought and discussion, but there's a long way to go. Thank you very much.
Hey, Dr. Emberton, thank you. We have a half hour or so for questions. Maybe we can talk you into sticking around a little bit after that. Just so people know what we're doing next, Rochelle is going to be responding to or presenting questions that were emailed to us in advance. Jeff and David will look at questions submitted today. And I'm going to start off with a couple of questions myself. This one is from Doug, and he's a big fan of the My Prostate Score 2.0 test. And he's wondering how this can be used. Could it be, and by the way, there's a new version of the test. There's a new algorithm for active surveillance. It hasn't been approved yet. But,
Right.
Can that be squeezed in before the MRI, or how would that work, do you think, Dr. Emberton?
Yeah, I think I think it can. I mean, the MRI provides so much information. If you have a normal MRI, you don't get a biopsy. So there's Gleason. We don't make the diagnosis of Gleason 3+3. If you've got a lesion, then the size of that lesion and the nature of that lesion is hugely important. And so what we're seeing is active surveillance is changing from monitoring men who were diagnosed with Gleason 3+3 because they had random biopsies to men with viable tumor masses or lesions in their prostate that are cancers, right? And for whatever reason we decide to watch them, and that's very, very different. And so those two groups are really, really different. And I think they need to be managed very differently. So if you've got a lesion, you need regular MRIs because you need to watch it very closely. If you haven't got a lesion, then your risk of transforming to somebody with a lesion is quite low. But actually, you can use MRI to identify individuals that go from no lesion to a lesion, and that would be a trigger for escalating treatment. The trouble with all the algorithms is that they're all using quite old data, and not many of them are incorporating the MRI information. And what's happening is that active surveillance is changing everywhere because of many of the things I've said today and many of the things I said at the last talk.
Well, but let me press you.
Sure.
Doug specifically was asking about a biomarker, My Prostate Score 2.0. Are you familiar with that? And
No, I don't know that one. We don't have any biomarkers. No biomarkers have been approved in the UK to date. None of them have made the grade through NICE. Zero. So
Well,
PSA is the
you
only
should
biomarker.
explain
Yeah.
who NICE is.
Okay.
That's
It's like the FDA. So the National Institute of Clinical and Care Excellence evaluate new tests and decide whether or not they are cost effective. And if they are, they're approved. And if they're not, they're not.
well,
And yeah,
yeah, there are a number of these biomarkers in use routinely in the United States, and my prostate score 2.0 has a particularly high sensitivity and so on. And their claim, I think, is that they can avoid 50 to 60% of biopsies. So I think what Doug is getting at, if that's true, where does the MRI fit in?
well, we
I,
don't do any biopsies in active
yeah,
surveillance. A man can present, and if he has a normal MRI, he's discharged. If you biopsy that individual, you have a 30% chance of finding some Gleason 3+3. So we're avoiding, if active surveillance is a response to a medical error, in other words, the identification of disease that does not require treatment. Yeah. So if active surveillance is a kind of mitigation on unnecessary treatment, you can go one better and not make the diagnosis in the first place. Right. And that's where we are. That's what what we're striving to do. And that's what avoiding biopsies does, is that it reduces the number of men who are given a Gleason 3+3 diagnosis.
you just made the comment a few minutes ago about actually, you made it at least twice. And, it's kind of a powerful thing for those of us who are carrying around
Yeah.
these lesions. All lesions will grow, but you say you've seen none disappear. But let me
No, no,
question.
no, no, no. So not all men will have a lesion. No, I hope I don't have a lesion, but I could be carrying Gleason 3+3. I have a 30 to 40% of having Gleason 3+3 in my prostate today, just on my age. But no, not all men have lesions. So most of the men that we scan with a high PSA have a normal MRI, they're reassured and they're discharged.
Well, I thought you said all lesions will grow.
Correct. They do.
Okay.
And
Let
I
me,
showed you data to support that. So not all men have lesions. If you do have a lesion and it's a cancer, they all grow. I showed you the graphs, right?
yeah.
So a lesion is an organized tumor mass. So it's a cancer that has grown to 100 million cells, has picked up a blood supply, has evaded the immune system, has overcome tumor hypoxia, has enough heterogeneity to overcome a lethal mutation. So it's gone a long, long way from a single cell that you might pick up, or a small group of cells that you might pick up on a random biopsy, to a viable tumor mass that is organized to such a degree that you can see it and differentiate it from the background tissue on ultrasound, on MRI, and PSMA PET. Those lesions do not go away.
Well, okay. So there are a number of us in this virtual room, like me, who have been diagnosed, say, with a Gleason 6, and I was with a single core, less than a millimeter. Some
Yeah,
some doctor wanted to take my prostate out next
sure.
Tuesday, but and I ended up having 5 more biopsies, and
Yeah.
the cancer was never seen again. I had an MRI last summer, and I'm not looking for personal advice or anything like that, just an example. And I had a biparametric MRI this last summer, and they didn't see anything. So do I still have the cancer or do I not have the cancer? It's 15 years.
No, so nobody knows. So hopefully that wouldn't happen to you today, because what you'd do is you'd have an MRI and you'd be told the MRI is normal and you'd be reassured. You would have been saved 5 or 6 biopsies. My own personal view is that these small microfocal cancers, most of them go away. The immune system takes care of them, by far the majority. There's no way of knowing that because you can't see them, you can't repeat the biopsies, with any degree of accuracy because the needle never goes to the same place, and they are not destined to form a tumor mass. What I am saying is that once you've got a tumor mass, it's not going to go away. That's very, very different from what you're describing, Howard.
Okay, I'm going to ask two more questions, then I'm going to turn it over to Rochelle, followed by David, and then Jeff. But there were a couple of questions about whether Tesla 3 is the standard. That's what we used to be told. But is it correct or incorrect that some of the newer 1.5 Teslas have even a better resolution?
Yeah.
And as a follow-up to that too, is there any advantage today to a Tesla 7? I'm not talking cars here. So
Yeah, no, sure. No, an up-to-date 1.5 works great. We tend to use a 3. It's what our radiologists like. 7, you can get wonderful pictures. We don't have access to 7. The only 7s that we've got in our hospital is a brain 7. Whether or not that will become commonplace or not, we'll have to see. What's really interesting is the lower magnet strength. As the technology gets better and better, you're getting to Tesla 0.51. So you're getting to really low magnet strengths that are starting to show prostates reasonably well. So and we're getting some of the 1.5s now that Siemens are developing. You are much lighter. They can be put in an apartment building. They don't have to have a quench pipe. They don't, they use a lot less electricity. So I think we're going to see a lot in terms of more MRI availability in terms of access, which clearly is needed in some jurisdictions.
I hear you. Rochelle, why don't you weigh in?
Sure, thank you. So we did get a few questions by email before the meeting. One of them is asking if an MRI shows PI-RADS 4, but the targeted biopsy ends up being negative, what would the most likely explanations be? And what would be a good follow-up strategy for a patient in that situation?
So that's a really great question. In fact, there was a paper today published on that. So the general advice at the moment is to be reassured, right? So if you have a PI-RADS 4 lesion, remember PI-RADS 4 has about a 70 to 80% chance of being a cancer. Not everything we see is cancerous, and if it comes back negative, particularly if there's inflammation there, it's likely that lesion will disappear. It's not a cancer. All right. It's likely that lesion will disappear when you rescan the individual a year later. So if the general advice, I think, in all the guidelines and my own practice is to repeat the scan in a year. If the lesion's gone, great. Patient can be discharged. It was a false positive. If the lesion is still present or any bigger, then you might start to consider a rebiopsy because you can miss cancers. And again, I was quick. You can miss cancers because your targeting is incorrect, but you can also miss cancers because the tissue capture is incomplete. So the process of biopsy is a very inefficient one. And as we know, the prostate is different in every man, and the prostate is different in texture throughout the prostate. And the chamber, when you're doing a biopsy and you look at the chamber of the biopsy gun, it's never full. It's always kind of half full or a third full, and you kind of wonder where that bit of tissue came from. And it might have come from before. So in other words, I'm talking about the Z plane now. So the tissue may have come before the cancer or after the cancer and not in the cancer. So there's a randomness to the process. So I think the general advice is be suspicious of the lesion until it goes away.
Okay. Perfect.
Can I
Thank
interject something there too? So do you not consider Gleason 6 a cancer?
I don't, no. I mean, and I've written articles, suggesting that it doesn't metastasize. Nobody's ever died of it. Lesions, visible lesions, never Gleason 6. They've always got some pattern 4 in them. Now you may miss the pattern 4, but if you repeat the biopsy, you always find 4, and you'll be wrong very, very rarely. So Yeah, I don't think it might be a risk factor for more aggressive cancers, but I don't think Gleason 3+3 necessarily becomes Gleason 3+4 or 4+3.
Sorry, Rochelle, go ahead.
No, no worries. That answered that. Do you want me to ask another one, or you want to
Yeah.
move on? Okay,
And then we'll
great.
move over to David.
Okay, so another question that we got by email was, how do you balance the benefits of repeat biopsies against the harms over time? And how do you individualize biopsy frequency rather than using a fixed number?
So I think we want to do as few biopsies as possible. We've got people on surveillance who've never had a biopsy. So in other words, an older man with a small lesion that seems to be stable over time. And what that individual has is an MRI once a year, once every 18 months or so, with a PSA every 6 months. I notice, I mean, in the patients that I share with American urologists, there's always a much lower threshold for doing a biopsy. So the advice the patient is getting locally. So I've got a couple of patients in LA at the moment, and they're being told to have a biopsy, and I'm saying, no, I don't think you need one. So it's interesting, the threshold. So I'm a lot more reliant on the imaging, and I think culturally, the American urologist is more reliant on the pathology. And we work in very different jurisdictions. There's no criticism. It's just different. So we and there are times when you need a biopsy. I mean, the case I showed, I'd been watching the 3 lesions. He was about to go to HOLEP. We wanted to make sure that that we knew exactly what was in the prostate before we changed the prostate. And I think it was not an unreasonable thing to do. He did have a HOLEP. We're letting that settle down now, and I'll watch the lesions in the peripheral zone if they still exist, and then we might treat them focally if one progresses. So knowledge of the lesions, they were all 3+4 from memory. So I think as a principle, we really want to reduce the biopsy burden. Yeah, but occasionally there'll be a very good reason to do a biopsy. That tissue and knowing that there's no Gleason 5 there will be important.
Yeah.
Perfect. Would you mind if I just
how about giving David a chance?
Sorry, go ahead.
Can you hear me okay? I've got a new mic hooked up
Oh,
here. This is David Keller in Florida.
You sound like Arthur Godfrey.
Oh, okay, great. Dr. Emberton, thank you so much for your presentation. Wow, incredibly enlightening. We're so fortunate to have someone with your skill, background, brilliance, insight sharing with us. And let me ask a question about PSMA. When I first entered this world, PSMA was an exotic last,
Yeah.
But now it sounds like it should be more universally used. Could you talk about that? Like, if someone has a PI-RADS 5, for example, should they jump to a PSMA? And how I know PSMA historically was supposed to look at metastases outside the prostate, but can you talk about it that it can also see inside the prostate as well?
Yeah, no, it's a great question.
One, how soon should we jump to a PSMA with the PI-RADS 4 or 5, and what can it see inside and outside?
Yeah, I think straight to it would be my answer. So that's what I would do. If I had a PI-RADS 4 or 5, I would want to characterize it as well as possible before anybody thought about a needle, right? Because I want to keep my options open. So first of all, if you get a double hit, as I've illustrated, I think beyond doubt now, it's 100% chance of being a cancer, right? And a 99% chance of being clinically significant. That's a huge amount of knowledge. Yeah. And also remember that the PSMA PET rules out disease to the best of our ability elsewhere in the body. So you've got an organ-confined prostate cancer without sticking a needle in. Yeah.
Right.
And the other kind of nice thing about PSMA PET, remember, if you have a biopsy and you find Gleason 5, what do? A PSMA PET. If you've done it already and showed that there's no spread, basically you've ruled out metastatic Gleason 5. So you've done a huge amount. The only trouble with PSMA PET is that it's very expensive in most countries. In Australia, it's kind of $600. I don't know how they do it. In the UK, it's about $2,000 to $3,000. I suspect in America, it's something like $4,000 to $5,000. Looking at MRI prices, so accessibility is problematic and cost is an issue. But if we put cost aside at the moment, um, um, yes, I mean a large proportion of men would benefit from having an MRI scan followed by a PSMA PET, and then a discussion about biopsy.
Thank you. And I know that a lot of us are concerned about MRI gadolinium toxicity. Is there any toxicity? Don't they put some sort of a radioisotope or something into your body?
No, of course, yes. So we're doing more and more MRIs now without gadolinium. Unfortunately, PSMA PET is a radio tracer. It's an isotope, and you have a CT scan in the background, to kind of hang everything on. So it's a significant radiation dose. So it's not something that you could repeat, but as a kind of one-off staging scan, I think it's probably justified. But I don't think it's a monitoring scan because you'll have cumulative increase in dose. Now they're working hard to try and get the dose down, so you can just do a PSMA PET scan of the pelvis, and therefore you don't get the dose on the head and the toes. And there are lots of ways that they are working towards trying to reduce the amount of radiation. But it will always involve radiation, because it's a radio tracer.
It's a radio tracer. Thank you so much. I'm going to turn it over to Jeff. Thank you so much, Doctor.
Thank you.
Pleasure.
Thank you, David. Doctor, thank you. Calling from Northern California. I'm very humbled to hear from you today. We have a question. I have two questions. One from Kenneth Haynes. Why wouldn't a PSMA PET scan be suggested prior to a biopsy following a PI-RADS 3 rating? It seems that this would be less invasive and more accurate than biopsy.
I think, in Australia, this is not discussed. They do PSMA PETs on low risk patients contemplating active surveillance. Whether it helps in a PI-RADS 3 lesion, I don't know. I haven't seen any data on that. But that's probably the next place we need to go. I suspect, right? So this is my hunch, and I don't have any data to share with you, that you will probably get an indeterminate. Remember, PI-RADS 3 is an indeterminate signal. The radiologists can't quite say it's normal, but they can't quite say it's abnormal. PSMA PET is also on a 5-point scale. It's called the primary scale. They have a big 3 as well, and quite a few are indeterminate. And what they describe is non-specific bilateral symmetrical changes in the prostate, not dissimilar for the MRI. So I doubt it would be that helpful in the PI-RADS 3 lesions. The PSA density is very helpful, in the PI-RADS 3 lesions, and the repeat MRI is very helpful in the PI-RADS 3 lesions. So in other words, is there greater focality? Is the signal intensity getting greater with time, which obviously would be worrying, or is it stable or getting less with time?
Okay, Doctor, a second question. I was going to ask more along the line of if we treat by tracing certain cancer cells, why can't we biopsy or MRI with that same technology and science? Does that make any sense? If we can treat with one, why can't we track or image with the same kind? I don't know if it's called radioligand therapy or what, but it seems to me we're able to track cancer, then why can't we track it with imaging?
Well, we can, and there are PSMA PET therapies. These are theranostics. So obviously, again, so if you PSMA PET works by an antibody which is labeled, and you can see the label, but you can also get that antibody on, and if you add, let's say, an alpha emitting particle, you can treat the lesion, and that's available. That's available now for metastatic disease, non-responsive metastatic disease. So you can treat with PSMA PET. With MRI, we've thought about it. So and I actually, I mean, you can have treatment in the magnet with lasers, with cryo, and with linear ultrasound. So you diagnose in the magnet and you treat in the magnet. We had a kind of crazy project once where we were going to put a pellet into the prostate, and then we were going to use the magnetic field in the magnet to move the pellet round in the prostate, and that proved very difficult because the prostate is pretty stiff. And then you can use the radio frequency current that you get inside a magnet to heat up the pellet, right? So, so you diagnose on MRI, and then you move the pellet round and then heat it. This is kind of Star Warsy. And then we've abandoned it, but they have not abandoned it in brain, right? Brain tissue is much softer, and you can actually propagate a pellet through brain tissue, but you can't through prostate on a standard 3 Tesla magnet today.
Okay, thank you, Doctor. Howard, that's all.
Okay, Jeff. Doctor, what is the miss rate with MRIs? And is it bad that it misses things? Does it mainly miss low-risk cancers?
It depends what it is that you want to miss and what it is that you want to find. I'm in the business of finding viable tumor masses. That's the clinically meaningful entity that I want to treat. Those seem to be all visible. Yeah, I've never seen one that isn't, but that's self-serving. It's slightly circular argument. I have no idea what the fate of a non-visible cancer is, nor does anybody else, because you cannot see it. You cannot study it. You cannot follow it up. All you can do is wait for it to, I mean, you can treat it as we did historically. And as they offered you, Howard, a radical prostatectomy, and that would almost certainly be over treatment, and you would suffer the consequences and not experience the benefits. So I think this notion that we are missing non-visible cancers is soon obsolete. I mean, this is kind of subject for debate, and I think I'll be debating it at this year's AUA. But if you think about how every other cancer is diagnosed, every other cancer, the cancer only exists when you see it on imaging. I mean, I'm excluding leukemias, obviously, but think about brain, breast, lung, liver, kidney. I could go on. The cancer exists when you see it. Why should that not be the case in prostate, which is much less lethal than all the other cancers I've just mentioned?
Okay, Keith asks, can MRIs miss small metastatic lesions?
Well, by metastatic lesion, we mean a lesion that's not in the prostate. Yes, of course. Of course they can, because every lesion starts with one cell. MRI is not great at lymph tissue. Whole body MRIs aren't that sensitive. The best test is PSMA PET. We used to use bone scan. PSMA PET came along, showed that bone scan was useless. I'm sure something else will come along that will say one day that PSMA PET is not as good as we thought. But that's the best way we have for detecting metastases at present. MRI is not a good method of detecting metastases.
But there is a miss rate for low risk cancers, right? With MRI?
Well, I don't see it because I don't biopsy normal MRIs. Therefore, I don't miss anything, right? So again, it's slightly circular, but it depends on, what is your therapeutically meaningful target? What is it that you are looking for? I'm looking for tumor masses. If I don't see a tumor mass, I reassure the patient. If you are looking for tiny bits of Gleason 3+3, then you've got to biopsy everybody that's walking down the street, but not just biopsy them. You have to biopsy them in the best way you can, which is 5 mm template sampling, which has a 95% chance of ruling out 0.2 cc lesions if negative. And that's 100 biopsies in a 40 cc prostate. Nobody does that. And therefore I question their desire to find these lesions, and this is the argument I always have about systematic biopsies. You're only putting 6 cores into each side of the prostate. That doesn't. You have no chance of finding microscopic disease with any degree of certainty. So in all other cancers, we're looking for lesions, and that's what I'm doing in the prostate.
Yeah, Rochelle, you can pick it up now.
Sorry, unmuting myself.
I have to
Okay.
go quite shortly. Yeah,
Okay.
it's 6:30. I've got to go quite shortly. Yeah.
Okay, I'll just do one last one then. So from a patient advocacy perspective, for men who aren't offered an MRI before their biopsy, what would be your advice for how they can advocate for themselves, and maybe what questions they could ask to?
I mean, I'm truly shocked by the data that the majority of US men are not being offered an MRI prior to biopsy. I think it's scandalous. I think the AUA should be doing something about that. Because you just can't have this type of conversation unless you've got information on your prostate. I don't see a patient unless they've had an MRI beforehand because there's nothing to talk about. Yeah. What we'll do is look at the MRI together and we'll say, look, there's a little bit of something over here. I'm not too worried about it. Let's repeat the scan in a year. These are all men with a high PSA, or your scan is normal. Off you go. Come back to me if your PSA goes above a certain number. Or, look, I'm worried about this thing, at 3 o'clock. Should we watch it or should we do a biopsy? So that's the conversation you can have with an MRI. If you haven't had an MRI, there's no conversation. I think these individuals are probably going straight to transrectal biopsy, non-targeted by definition because nobody's elicited a target. That's terrible care. So I think men need to know. They need to say, stop. I want an MRI first. We know that it's cost effective. We know its clinical utility. It was recommended by NICE, National Institute of Clinical Excellence, in 1990. It's been around 7 years. We've got 10 randomized trials showing that MRI improves the chances of finding clinically significant disease. I could go on, but I think this is a huge disparity in terms of access to not even high quality healthcare, basic healthcare kind of provision.
I have to put in a word for AUA. I think their guidelines do recommend MRI, but I think it's in the context if it's available. So why isn't it available?
Yeah. No, I think and groups like yours, and it would be quite nice if some senators or congressmen put their head above the parapet and started campaigning on this. I don't know how it works in the US, but whether one can get government to start, because it's quite a simple demand actually. There will be MRIs available. They're in every hospital. It's just how you use them.
And David, do you have another question?
Well, we want to let Doctor go because he has to go to it right away. But if I could sneak in one question that may benefit a lot of the people in the audience, if you've got a lesion in the transition zone and the aquablation hoses out a lot of the transition zone, is this something that your group is looking at in terms of one treatment option for lesions that are in the transition zone that may show 3+4 or in that category?
Yeah. I mean, we don't have much experience with aquablation. What we tend to do after aquablation or holmium laser prostatectomy, we do a lot more of. The MRI looks inflamed for about 6 months afterwards, so you need to let it settle down, and then you reevaluate the much smaller peripheral zone of the prostate. If the cancer was in the transition zone, then there's no reason why an aquablation or a HoLEP can't get rid of that. but you want to make sure that it's all got rid of. But you do have to wait about 6 months for everything to settle down and the prostate to settle, and then it's much easier to evaluate.
Yeah,
Thank you.
yeah, Jeff, one last question.
Sure, thank you, doctor. For those of us who have a grapefruit-sized prostate, do you have any ideas about suggestions about the MRI, how our care might be different from men who have a smaller, perhaps a golf-sized prostate, golf ball?
How about a hockey puck shaped one?
I
Yeah, I mean, I showed you a very large MRI. In fact, I showed you two very large prostates. Big prostates image very nicely. They're just hard to treat, right? So they're very difficult to do focal therapy, and if that's what you're after, just kind of hard to reach, and you push people into retention and stuff like that. And so these days, when faced with a large prostate, we tend to make it smaller with aquablation or HOLEP, and then reevaluate. And that strategy works pretty well.
Okay.
We
All
need
right.
to let the doctor go. He's been
Yes.
very generous with his time. And thank you so much, Dr. Emberton. I had mentioned because of sepsis, I hadn't had a biopsy for 21 years, but you've given me so many reasons to not do that. So thank you. And thank you on behalf of all the men in ASPI. This has been very revealing.
Wonderful. Well, it's been a great pleasure and privilege to spend some time with you all, and I wish you all well.